Welcome to this presentation on shoulder dislocations. We'll talk about three types of shoulder dislocations: anterior, posterior, and a kind of funny one called Luxatio Erecta. We'll wrap things up talking about pseudodislocation so that you don't accidentally try to relocate a shoulder that is actually appropriately located. We're going to talk about a couple of important associations, but you'll probably need to supplement the material from this presentation with some readings to be able to learn all of the important associations that you need to know about. This is a dried bone specimen of a normal shoulder, and I know that all of you guys have taken anatomy, and what I'd like you to do is try to identify the glenoid, the humeral head, the coracoid process, and the acromion process. Don't worry if you don't know that. We will spend a little time in a little while going over exactly where these structures are located. The shoulder is the most mobile large joint in the body, which is good because it helps us to be able to manipulate objects in space. There's a downside to that, of course, and that is that the shoulder is the most commonly dislocated large joint in the body. Let's take a look at the anatomy. You can see that you've got a very big humeral head and a relatively small glenoid, and this is what allows the shoulder joint to be so mobile. Of course, the downside of that is that there isn't a lot of stability and that the shoulder dislocates fairly easily. On the left is a radiograph of the shoulder, and on the right is a dried bone specimen. Again, look at the articulation between the glenoid process and the humeral head and try to appreciate where the coracoid process and where the acromion process is located. The anatomy on this view, I think, is pretty straightforward, but there are two other views of the shoulder that we depend on frequently to tell us in which direction the shoulder is dislocated, if in fact it is dislocated. So we're going to go over those views in just a second. Those two views are the axillary view and the scapular Y view. The axillary view is on the left and the scapular Y view is on the right. And what we're going to do now is we're going to go over how these views are obtained, because understanding how these views are obtained will help you to properly interpret these views when they're abnormal. And we'll start with the scapular Y view. On the left is an image of a model of the right shoulder obtained in an AP projection, in other words, directly from the front. And on the right is the same thing, with the shoulder rotated 45 degrees toward the camera. As you can see from the image on the left, the shoulder is already pointed anteriorly somewhat. You can see that we're getting a view of the surface of the glenoid process there, which is circled in red dots. And I've labeled the acromion and the coracoid process for you also. On the image on the right with the shoulder model rotated 45 degrees, you can see that we're looking right down the barrel of the glenoid. And this is how we obtain our scapular Y view, by rotating the patient up toward the camera in the case of the picture here, but the X-ray tube in the case of when we obtain an X-ray. You can see also that the coracoid process points anteriorly and that the acromion is a relatively posteriorly located structure. And this is going to be very important for us to be able to determine whether or not a shoulder is dislocated anteriorly or posteriorly. So this is what you get in terms of a dried bone specimen when you get that scapular Y view. Now, why is this image, or why is the resulting image called a scapular Y view? Well, if you connect the acromion, the coracoid, and the blade of the scapula like this, you can see that that forms a Y, and where those three elements of the Y come together, that's where the glenoid process is, and I've circled the glenoid process with the red dots. On the right is an image of the same thing, except here the humeral head is included, and you can see that the humeral head sits right where those three elements of the Y come together, right where that glenoid process is. This is a normal location of the humeral head. This is a properly located shoulder. On the left is a scapular Y view that shows exactly what we've been talking about. The humeral head there projects over where we expect the glenoid process to be. Remember, when we draw those lines that connect the acromion, the coracoid, and the blade of the scapula, where those three lines come together, where that Y forms, that's where your glenoid process is, and that's where your humeral head should be. The key thing to deciding in which direction a shoulder is dislocated is where the humeral head comes to rest in relationship to the coracoid and the acromion process. So normally the humeral head sits where those three elements of the Y come together. The coracoid, remember, is a relatively anterior structure and the acromion is a relatively posterior structure. So if your humeral head comes to rest in the region of the coracoid process, that's an anterior dislocation. So that would be what an anterior dislocation looks like. A posterior dislocation, obviously the humeral head goes in a posterior direction. So the humeral head will come to rest in the region of the acromion process, something like this. Okay, so that is the scapular Y view. Let's talk about the axillary view for just a second. And the axillary view is obtained exactly like you would think it is obtained. Basically, it's obtained by taking an X-ray beam and shooting straight up into the axilla or the armpit. So the arrow there on the image on the left illustrates the direction of the X-ray beam. The resulting image that you get is depicted there on the right. So you can see that the glenoid articulates with the humeral head, and you can see that the acromion is a relatively posterior structure, again, just like with the scapular Y view, and that the coracoid, which I've labeled there anteriorly, obviously that's an anterior structure. So the image that you get, the axillary Y view, the axillary view is what you see there on the right. So on the left is an image, an actual X-ray image of an axillary view, and on the right is the dried bone specimen, again showing that the anatomy is exactly what we would expect to see on the X-ray. Alright, let's talk about some of these dislocations, and we'll start talking about the anterior dislocation. Most humeral head dislocations are in an anterior direction. Something like 90% of humeral head dislocations are in an anterior direction. Now this is fortunate because these are relatively easy to recognize. So on the left is a normal X-ray, and on the right is a patient who has an anterior dislocation of the humeral head. And no one is going to miss this dislocation. This is a real obvious dislocation, and this is a classic appearance for an anterior dislocation of the humeral head. Now, if you're a novice, it might be difficult to tell exactly what direction the humeral head is dislocated, and you can get some help in that respect by looking at these other views, this axillary view and the scapular Y view. So let's go ahead and look at some of those views. On the left is a radiograph of a scapular Y view in an anterior dislocation, and you can see that the humeral head there has come to rest beneath the coracoid process. These dislocations are sometimes called subcoracoid dislocations, and if you draw that Y where those three elements come together, that's where the glenoid process is supposed to be, and you can see that the humeral head here is located anteriorly to where you would expect the glenoid to be. This dislocation has occurred in the direction of the coracoid process, so this is an anterior dislocation. On the left is a radiograph obtained in an axillary projection, and on the right is a dried bone specimen, basically illustrating the same thing. And again, you can see that the humeral head has dislocated in the direction of the coracoid process, so this is an anterior dislocation. One more thing I want to emphasize about this case, you can see that the humeral head is actually smashed into the glenoid process, and I've illustrated that on the image there on the right, where we photoshopped in an impaction fracture of the humeral head. This type of fracture that occurs secondary to an anterior dislocation is called a Hill-Sachs fracture. So this is a potential complication, one of the associations that you need to know about in patients who have anterior dislocations. Let's move on and talk about posterior dislocations. Posterior dislocations are relatively uncommon. Something like 10% of humeral head dislocations are posterior. These can be very difficult to recognize, and we'll talk about why that is in just a little while. Common history in patients with posterior dislocations is that the patient has had a seizure, and after the seizure there's difficulty moving the shoulder, and there may be some pain also. So keep in mind, if you have somebody who has had a seizure and who has difficulty moving the shoulder, that you need to think about posterior dislocations. Both of these images show posterior dislocations, and they're a lot less obvious than that anterior dislocation that we looked at just a little while ago. In fact, the image on the left there, it looks like the glenohumeral joint is a little bit wide, and on the right it looks like the glenohumeral joint is a little bit narrow. You can see that there's actually some overlap between the glenoid and the humeral head on that example on the right. And that's a very sort of confusing characteristic of posterior dislocations, that they can make the shoulder joint look too wide and they can make the shoulder joint look too narrow. And we'll try to understand why you can have two sort of opposite imaging features for the same process. On the left is an example or an explanation of why the humeral joint, glenohumeral joint, might look too wide. You can see that the humeral head there is posteriorly located with respect to the glenoid, but it's sort of perched on the back of the glenoid. So the shoulder joint there might look too wide. On the right, you can see that the humeral head is sort of pushed medially with respect to its normal articulation with the glenoid. So the shoulder joint there on the right, if you took a radiograph of that, that would look too narrow. So that explains why you might have a shoulder joint that looks too wide or too narrow with the same process, with a posterior dislocation. So what do these things look like on the scapular Y views and on the axillary views? On the left is a scapular Y view of a posterior shoulder dislocation. Again, if we sort of put those lines together, connecting the acromion, the coracoid, and the blade of the scapula, that's where the humeral head should sit, because that's where the glenoid is going to be located. And you can see that the humeral head there is posteriorly located with respect to where we expect the glenoid process to be. This is an axillary view, and you can see that the humeral head is not appropriately located. You can see that the humeral head and the glenoid do not line up appropriately. And you can also see that the humeral head is posteriorly located with respect to the glenoid, because it's pushed in the direction of the acromion process. And that's illustrated on the dried bone specimen there on the right as well. Occasionally it might be helpful in a very confusing case to get a CT scan to better delineate the anatomy. You can see from the CT image there on the left that this humeral head isn't frankly dislocated, it's subluxed. In other words, it's pushed posteriorly with respect to the glenoid, but that there's not frank dislocation. The other thing that I want you to appreciate there is that the glenoid has gouged out a piece of the humeral head. This is called a reverse Hill-Sachs. So a Hill-Sachs deformity is the fracture that you get involving the humeral head that occurs as a consequence of anterior dislocation of the shoulder, whereas this reverse Hill-Sachs is something that you get as a consequence of a posterior dislocation. And on the 3D reconstruction that we have there on the right, you can see that I have circled with yellow dots that impaction fracture of the humeral head. This has been called a trough sign. Alright, the last dislocation, very rare, I've only seen 2 cases in my entire life, is Luxatio Erecta. And this has a very characteristic appearance. You can see that the humeral head is inferiorly displaced with respect to the glenoid, and you can see that the arm is going to be, or the humerus is directed superiorly with respect to the scapula, and that's very different from what we're used to seeing. With the anterior and posterior dislocations, the humerus remains in sort of an inferior location. So let's look at a couple of images. On the left is a radiograph of a patient with a Luxatio Erecta, and it looks exactly like what we would expect based on the dried bone specimen that we just looked at. The humeral head is inferiorly displaced with respect to the glenoid. You can see that the humeral head and the glenoid are not articulating appropriately, and you can also see that the humerus is directed superiorly. So clinically, what you're going to see is that the arm is going to be held up above the patient's head. Alright, very briefly we're going to talk about something called pseudodislocation. On the left, you can see that the humeral head looks a little bit inferiorly displaced with respect to the glenoid on this AP view, but on the scapular Y view, you can see that the humeral head is appropriately positioned. So if we connect those lines, connecting the coracoid process, the acromion, and the blade of the scapula, you can see that the humeral head lives right where we would expect the glenoid to be. So this patient has a properly located humeral head. This is a pseudodislocation. What's happened here is that the patient has a fracture of the neck of the humerus, which I've circled there in red. That's resulted in bleeding into the shoulder joint. This is a fracture that is within the shoulder joint. So because of that hemorrhage, there's increased pressure in the shoulder joint, and that pushes the humeral head inferiorly with respect to the with the glenoids. This is not actually a dislocation. This is a pseudo-dislocation. So obviously you don't want to relocate a shoulder that actually is already located, because I think the patient would probably get pretty annoyed very quickly with you, because they're going to be in considerable amount of pain because of their fracture. This ends our discussion of shoulder dislocations. Thank you.